Physiology SAQ5 Control of Body Water. A. Describe the function of the nephron and collecting ducts in water diuresis following a water load, 5 marks. Sensor. Following a water load, blood osmolality decreases and homeostasis is disturbed, which is detected by the osmoreceptors in the hypothalamus. The threshold for detection of a change in plasma osmolality is plus minus 2% for hypothalamic osmoreceptors. Volume receptors respond to volume changes above 7 to 10%. The effect via volume receptors will be to inhibit ADH secretion to allow water excretion. Central controller. The hypothalamus then signals the posterior pituitary to reduce ADH secretion from the supraoptic and paraventricular nuclei. Effector. Reduced ADH causes reduced thirst and water consumption and reduced water reabsorption at the distal convoluted tubule and collecting duct. By reducing aquaporin insertion at the apical membrane, this results in production of a large volume of urine and diuresis. Blood osmolality increases and homeostasis is restored. The plasma half-life of ADH is about 15 minutes. ADH is inactivated in the liver and kidneys. Hence, after a water load, reduced ADH secretion results in rapid offset of ADH effects and rapid onset of water diuresis. Urine osmolality. Random urine specimens have an osmolality of 50 to 1200 milliosmol per kg H2O. A huge water load can cause production of urine with low osmolality of less than 100 milliosmol per kg H2O. Following a water load, the absence of ADH results in very low urinary sodium levels of 80 to 100 millimole per liter due to dilution from water diuresis. Volume expansion will stimulate the secretion of atrial natriuretic peptide, which causes increased GFR and filtration fraction, natriuresis and diuresis, reduced blood volume and reduced blood pressure, inhibition of renin release, resulting in reduced angiotensin II and reduced aldosterone and their effects, such as reduced SVR, vasodilation, natriuresis and diuresis, vasodilation and venodilation. B. Describe the function of the nephron and collecting ducts in osmotic diuresis in diabetes mellitus, 5 marks. Hyperglycemia in diabetes mellitus could cause increased glucose to be filtered through the glomerulus, and once the rate of filtered glucose load exceeds the proximal tubular maximal glucose absorption capacity, this excessive load of glucose would not be reabsorbed any further. As an osmotically active solute, glucose in tubular fluid prevents further water reabsorption, resulting in the excretion of a large amount of urine. Urine osmolality might be normal, i.e. similar to plasma in osmotic diuresis, in contrast to the reduced urine osmolality in the case of water diuresis. Urine osmolality of 100 milliosmol per kg H2O indicates a water diuresis as seen in diabetes insipidus or primary polydipsia, whereas a value between 300 and 600 milliosmol per kg H2O indicates an osmotic diuresis. This graph demonstrates glucose handling by the kidneys. The x-axis is plasma glucose in millimoles per liter. The y-axis is glucose in mg per minute. The filtered line demonstrates that the amount of glucose filtered by the kidney is directly proportional to the plasma glucose concentration. The reabsorbed line matches the filtered line until plasma glucose of 11 millimole per liter and then starts to flatten out as it approaches maximal tubular reabsorption, Tmax, at 300 mg per minute. Beyond plasma glucose of 11 millimole per liter, glucose is excreted in the urine as indicated by the excreted line, which rises parallel to the filtered line as plasma glucose continues to rise.